Good evening, ladies and gentlemen. Requested Vice President of our organization, Dr. Manik Prabhu, and distinguished speaker of this evening, Dr. Ramana Rao, our General Secretary, Dr. Durgaprasad Rao, our ICMR Director and Treasurer, Dr. Venugopal Gouri, and my dear friends, Dr. Goutham, Dr. Shruti, Dr. Harshita, and all the audience and audience online. So hearty welcome to you all. So we are organizing a memorial oration in memory of Dr. B.K. Kumar. Dr. B.K. Kumar was a very dedicated personality. He was one among the founder members of our association, and he was also an honorary consultant in our dispensary. He served for very long in our association. So we pay our heartful tributes on this occasion. And we also thank the family members of Dr. B.K. Kumar for sponsoring this event, Mrs. Ananda Gouri and the other members of their family. We profusely thank them. So today we have a very young, dynamic homeo physician, Dr. Ramana Rao, who is going to deliberate on COPD, chronic obstructive pulmonary disorder. This is a very problematic issue nowadays. So the incidence of this disease is very high and it is increasing day by day. So the main reason for this particular illness is cigarette smoking and increasing longevity and air pollution. So these are all on rise. So cigarette smoking is increasing, longevity is increasing, and the quality of air we breathe, they are also further deteriorating. So this being the challenge, how homeopathy tackles it, our young friend Dr. Ramana Rao would deliberate. So on this occasion, we also pay homage to Dr. Vishpala Parthasarathi, who passed away recently. So she was editor, National Journal of Homeopathy. So she rendered a great service in popularizing homeopathy. And to her credit, many literary works she did apart from the journal, running the journal. So we pay our heartful homage to her. So COPD being a very important topic, so we would be immensely getting benefited by hearing this lecture. So we are eagerly waiting to hear him. So thank you one and all.
Thank you, sir. Now I call upon Dr. Durgaprasad Rao sir to please say a few words about our association and B.K. Kumar Memorial Oration.
Good evening all. Respected President Dr. Gopal Krishna sir, today's our beloved speaker Dr. Ramana Rao, and our Vice President Dr. Manik Prabhu, and other dignitaries and all the doctors. First, let me pay my tributes to Dr. B.K. Kumar, on whose name today we are conducting this program. And you know the HMAT for the last so many years conducting OPD services and specialty clinics with various honorary consultants and duty doctors. And we thank all our consultants and duty doctors for their exemplary service in the homeopathic treatment here in this association at free of cost. And later on, we are doing other services like the training the house physicians for the posted by different colleges like JSPS, Dev's College, Amsa College, like that. And they have been posted here for some period as a routine official training program. And we have been training them thoroughly. And also, we conduct every month memorial orations on the last Sunday of the month, like this, on somebody's name. And we call expert lectures and from all over India. And we conduct the seminars, even one-day seminars also. And besides all these activities, we also conduct free medical camps and medical awareness programs for in the other areas in association with our other communities and other associations. All these activities are run by our many philanthropic activists and who are donating there in the form of money and matter and any or word, and their support you have been given by support from them. We thank all of them. And today's B.K. Kumar Memorial Oration, to say about B.K. Kumar, Dr. B.K. Kumar was a mathematics graduate from Nizam College and worked in the Department of Education for so many years. And while working in the department also, he developed a kind of sympathy, liking and interest in homeopathy. He learned homeopathy and became a registered medical practitioner and served till his retirement also. And after retirement also, he dedicated his full time in serving the patients and free of cost. From the beginning of our association, inception of our association, he was associated with us, with this attached to this institute, and he extended his services here also, honorary services in OP consultation, and he was a very dedicated person, confident person, and love for medicine and particularly homeopathy. And every year in the month of November, we conduct a memorial oration on his name. And this year, today, luckily, the young dynamic Dr. Ramana Rao has accepted our invitation for delivering the B.K. Kumar Memorial Lecture on a sigh of relief from COPD, chronic obstructive pulmonary disease, homeopathic management and treatment. I thank the doctor for his acceptance, and I thank you all for your patient hearing. Thank you.
Thank you, sir. Now I call upon Dr. Hima Bhuvana ma'am to introduce our speaker, Dr. Ramana Rao sir.
Good evening, one and all who are listening to this seminar online and who are present here offline. Good evening and warm welcome to HMAT. Every month they are celebrating seminars on so many topics. As November is the awareness month of COPD, so today we are discussing about COPD. I first of all thank you for inviting me to introduce about Dr. Ramana Rao Garu. Dr. Ramana Rao, who born in Hyderabad, father was in Air Force and he was an airman. Mother is housewife. His schooling was done in Hyderabad. He was active in sports and academics and leader in scouts and represented Hyderabad in Pachmari Scouts expedition held in Madhya Pradesh, and where he stood first in adventure sports category, which includes rock climbing, skydiving, forest expeditions, survival skills in forest, all these things. And he pursued his 11th, 12th from Sri Chaitanya Alwal and graduated from JSPS, BHMS, graduated from JSPS from 2011 to 17. He was my batchmate. Then later, he pursued MD in the same college. He worked as medical officer at Hamsa Homeopathic Medical College and Research Center from 2017 to 19. And he has also done MSc Psychology from B.R. Ambedkar University along with distinction. He's also co-founder, chief physician and counselor at Happy Pills Homeopathy, Kottapet from April 2023. His achievements were, he was university topper in pharmacy, MD, and also biostatistics. Achieved silver category in health research fundamentals from Swayam, conducted by IIT Madras. His hobbies are abstract painting, solving puzzles. He has immense craving for knowledge and he has selective reading. He has ability for selective reading of scientific articles related to science and tech. He also plays volleyball, badminton, all these things. Now I would like to invite him to present his lecture on COPD.
Hello. Good evening, everyone. I hope I'm audible to everyone. Thank you. Today is a very pleasant evening. I thank all the dignitaries who have invited me to present a case on COPD along with the management in homeopathy. How it is managed in allopathy and how we are trying to manage in homeopathy as well. I thank Durgaprasad sir. I thank Manik Prabhu sir. I thank Gopal Krishna sir for providing me this opportunity to present this case. So my case is, or my topic for today's discussion is a sigh of relief from COPD, its homeopathic management. What is COPD? COPD stands for chronic obstructive lung disease or chronic obstructive airway disease. It is the 7th leading cause of disability and also 4th most major cause of death. And it is predicted that by 2030, this is going to rise many folds. What is the cause of it? COPD is a disease in which air is trying to enter into the lungs, but is unable to get out of the lungs. So as the definition goes, it is a persistent airflow limitation that is progressive and associated with enhanced chronic inflammatory response in the airways and the lung to noxious particles and gases. So what are these noxious particles and gases which we are talking about in the definition? As the definition says, noxious particle and gases, it relates to all the environmental pollutions, which such as carbon monoxide, sand, coal dust, etc. There are two types of chronic obstructive pulmonary disease. Actually, there are four types, which includes bronchial asthma, chronic bronchitis, it includes emphysema, and also it includes bronchiectasis. But under the umbrella term of chronic obstructive pulmonary disease, it is chronic bronchitis and emphysema which plays a major role. And most of the disease come into this category. So what is chronic bronchitis? Chronic bronchitis presents with cough and sputum for at least 3 consecutive months for 2 consecutive years. So for example, in this year, 3 months, a cough should be present, and that cough should exist for 2 years to be distinguished it as chronic bronchitis. Whereas in emphysema, there is a permanent enlargement of air spaces distal to the terminal bronchioles, right? So which is accompanied by destruction of the walls without fibrosis. So there is no fibrosis in emphysema, but there is enlargement of the air spaces, right? We will talk about pathophysiology in the coming slides. Let us talk about the predisposing factors of COPD. The predisposing factors of COPD includes the age, which is the major thing, that is 40 years and above, and also the gender. Gender is a major predisposing factor, but now slowly it is fading away because smoking is gender neutral now. And especially in metropolitan cities, COPD is rampant. There are two factors. One is environmental factors and another one is the host factor. In environmental factors, tobacco smoke, indoor air pollution, occupational exposure, which is related to coal dust, silica, cadmium, low birth weight, lung growth, recurrent respiratory tract infection, low socioeconomic status, and cannabis use. So let me discuss about this in detail. So in environmental factors, especially for low socioeconomic group of people, we fancily write in our textbook as low socioeconomic group, but actually it is the poverty which gets affected more. Those who are living below the poverty line gets affected more with COPDs. And also those who live in metropolitan cities who are constantly exposed to obnoxious gases and also the dust, the coal dust, the silica particles, indoor air pollution. All these are the major contributing factors for COPD. The host factors include genetic factors in which there is some deficiency in alpha, antitrypsin, and also airway hyperreactivity. For example, if a baby or a person is constantly being exposed to all these environmental irritants, there is a predisposing condition which will lead to COPD, not immediately, but finally, like by the age of 40, he will be getting COPD, he will be diagnosed with COPD. That could be chronic bronchitis, that could be emphysema, that could be bronchial asthma, or that could be bronchiectasis. How does the COPD patient presents to us? He will present with a bare minimum of 4 to 5 symptoms. One is cough associated with sputum. Next is breathlessness, followed by wheezing and expectoration. So these are the things with which the COPD patient will be presenting to us. So related to cough, can anyone tell me like what is the type of cough, how will you differentiate it? So cough are of different types. Pneumonia, whenever a patient will come to you and you will find a cough, that is a very peculiar kind of cough which you will be seeing as soon as the patient is entering into the clinic. Right, you might have seen in Materia Medicas as well. What is the cough of calcarea carb? Bouts of 3, right? So a different set of cough will be presented by the patient, and that is very peculiar because in COPD, due to the collapse of the small airways, there is a loud sound and there is a pause, and then due to the obstruction of the airways in the expiratory phase, so how will he cough? Can anyone explain like how will he cough in COPD? Since air is entering inside, but is unable to come out. So there is obviously what is there? Yeah, there is dyspnea, but how is the cough? There is increased lung workout because he will be having inspiration, but there is lack of expiration. So he will take. So there is a peculiar type of cough, right? But in pneumonia, as soon as the patient comes, he will be like. So it is very easy to understand, like, because in pneumonia, there is no inspiration. There is no need, the cough doesn't need any inspiration. And also there is multiple repetitive bouts of expiratory cough. In pneumonia, there is expiratory cough, right? But in also, you will find that in acute pharyngitis, how the cough will be. Can anyone explain? In acute pharyngitis or laryngitis, right? The cough will be related to upper airway infection, right? So how the cough will be? That is known as boom cough. Boom cough. Right? So that is known as boom cough. So these are the peculiar kind of cough. As soon as the patient comes in, that is very easy to identify whether the patient is suffering from upper airway infection, or he is suffering from COPD, or he is suffering from pneumonia, right? Then there is breathlessness. That is shortness of breath, right? But in advanced stages of COPD, you will be finding edema because of salt retention. You will be finding edema, and also in acute exacerbation of COPD, you will be finding pitting edema. And also headache because of, see, air is entering in but is unable to expel. There is lack of perfusion, and carbon dioxide is unable to get out. So there is piling up of carbon dioxide inside the lungs. Once the piling up of carbon dioxide happens inside the lungs, there is hypercapnia. Since there is hypercapnia has a vasodilatory effect. Since vasodilatory effect is there, there is headache. And also you will find bounding pulse. The pulse will be bounding, right? You can easily feel that. That is related to hypercapnia. The breath sounds, wheezing will be heard, right? But if crackles are heard, that means COPD is associated with some kind of lung infection, bacterial infection. Or else, if persistent crackles are there, even after 3 months, if persistent crackles are there, even after 3 months, that indicates bronchiectasis. That indicates bronchiectasis. You know that obviously finger clubbing is seen. COPD is associated with finger clubbing, and also right heart failure. Right heart failure arises because there is pulmonary hypertension. There is pulmonary hypertension, which relates to backward shunting, and there is more action on right side of the heart. Since right side has to work more, there is right-sided heart failure, right? And also there is type 2 respiratory failure. What is type 2 respiratory failure? Type 2 respiratory failure occurs when the carbon dioxide is not expelled out by the lungs, right? That is type 2 heart failure. And there is pitting edema, I already discussed. There is fatigue, there is anorexia, weight loss, depression, and anxiety. I'll also tell you why anorexia happens and why weight loss happens. See, whenever there is any kind of inflammatory response happening inside the body, what happens, especially in the lungs, what happens is the first cells to respond is neutrophils and macrophages. Whenever these come into play, macrophages will be releasing TNF, right? You know TNF? TNF alpha. Exactly. It causes increased inflammation. As a result, the circulating TNF will cause weight loss. That is the reason the weight loss is more significant in COPD patients. And also, they will feel anorexic. because there is no intake of good calorie food. Since there is no intake of good calorie food and also there is circulating TNF, what happens is there is weight loss, there is anorexia, and ultimately depression and anxiety will also set in. Okay, so that is how the COPD patient will present. Let me reiterate again. One is cough with expectoration, breathlessness. In advanced stages, there will be pitting edema, fluid retention because of fluid retention, and also headache because of hypercapnia. There is wheezings. You will sometimes the husband or the wife will complain to the doctor because this was I have already treated this case. The husband was complaining, I am unable to hear the sounds which are coming from my wife, mostly from the lungs whenever she is breathing. Clear audible wheeze. Not even with stethoscope, but a clear audible wheeze will be heard. Right? Because narrowing of airways. It is like we are building a tunnel, because this is already in the news. We are building a tunnel. Workers are inside, just like oxygen, and the tunnel has collapsed. Right? Workers are the oxygen. Now the tunnel is collapsed. We have to bring the workers out. Right? What are we doing? We are pushing in the medicines. We are not trying to bring out the workers here, because this is already in news. There is a tunnel collapse which has recently happened where the almost like 13 persons have stuck inside the tunnel in North India. Right? A similar example. Similarly, our total lung system is a tunnel system. Whenever there is obstruction somewhere in the tunnel, air will get trapped inside. Right? Then what is the pathophysiology? Pathophysiology is very important in COPD because there are three types of things or three types of mechanisms which are going inside. One is inflammation, second is infection, third is airflow limitation. In inflammation, all the inflammatory mechanisms comes into play, which I have already discussed. But let me reiterate again. Because, so starting with inflammation, whenever our lungs come into exposure of the outside environment, right? Because only few organs are in direct contact with our environment, or that is that which is present in the external factors. One is the skin, the second is the lungs, the third is GIT, right? First is the skin, second is the lungs, and third is the GIT. These are the three areas which is in direct contact with the external environment, and whatever goes inside will definitely play a role in our health. Okay, so inhalational exposure triggers the inflammatory response in airways and the alveoli, and it triggers a protease activity. Remember, I have told you that there are certain predisposing factors, especially related to host, that is alpha antitrypsin deficiency. Alpha antitrypsin deficiency is a major role which is played in the COPD, because each person on the planet will attain a set of alpha antitrypsin from parents, one from the mother and one from the father. Right? So you have alpha trypsin, right? Alpha antitrypsin, which is inherited from the parents, one from the father, one from the mother. If there is any defect in this, if there is any defect in inheriting this alpha antitrypsin, what happens is there is defect in the creation of the hero of the scene, that is anti-protease. In this COPD, okay, there is a hero, that is anti-protease. If anti-protease is not formed, or if it is formed in a crippled way, what will happen is the antagonist, that is the villain, is the protease here. That is causing the inflammatory response. If anti-proteases are not formed in a healthy way, it won't be fighting all the inflammatory responses which are created by the proteases, right? What happens is a person will see, in metropolitan cities, smoking is very common. Especially at Madhapur, you will find a high-tech city and all, you will find a hell lot of smokers. We also smoke, but our inhalation is a different kind of inhalation. That is not the passive smoker. That is the smoke which is coming from automobiles, right? And also, if a person in the cabin doesn't smoke, but he wants to drink tea, he will come along with a person who smokes. He becomes a passive smoker, right? What happens is, as soon as the smoke enters into the lung, right? As soon as the smoke enters into the lung, there is a inflammatory response triggered. Okay, there is an inflammatory response triggered. As soon as the inflammatory response is triggered, neutrophils comes out, and also macrophages comes out. As soon as the see, there are two different mechanisms of neutrophil and a macrophage. As soon as the neutrophil comes into play, there is neutrophil elastase. Okay, there is neutrophil elastase. What does it do? It destructs the elastin, also the connective tissues. As soon as the connective tissues is destroyed, emphysema sets in. And also, similarly, macrophages. Macrophages also releases certain inflammatory responses. As soon as the inflammatory responses are entering into the play, what happens is it destroys the connective tissue of the alveoli, right? Once the connective tissue is destroyed, the next thing is emphysema sets in. Okay. Now, who will save this process happening? Like all the inflammatory processes is happening. Now the hero has to enter. Who is the hero here? Anti-protease is the hero. But due to the defect of the alpha antitrypsin, the hero is formed in a crippled way, or he's outnumbered, right? When he's outnumbered, what will happen? Destruction obviously sets in, right? And causes emphysema. That is as simple as that. There is no much fuss about it. It is very simple. Just that you have to remember that alpha antitrypsin deficiency is a major role in the host factor, right? In the host factor. And coming to infection mode, when infection sets in, right? When infection sets in, what happens is, tell me any two bacteria which causes infection. Any two bacteria which causes lung infection. One is Haemophilus influenza, and another one is Pseudomonas aeruginosa. These are the most common, and also Mycobacterium tuberculosis. You can have many infectious diseases, infectious bacteria causing infection in the lung. So what happens is, most of the bacteria, they will be settling in the lower lobes of the lung. We have already discussed that once the air is entering in COPD, it is unable to go out, right? When the infection is entering in along with the air, it is being trapped inside the lung. What will happen then? It will colonize inside the lung. Once the colonization starts, what will happen? Again, destruction, right? Once the destruction starts, it will form again, the whole pathology changes, right? That is the reason even in COPD, antibiotics cannot do anything. Similarly, in inflammation, cessation of smoking cannot do anything. It is already proved that even if you stop smoking, the inflammatory response, once it has been triggered, it will be going on. And even the steroids cannot do anything to stop the inflammation. That is the reason allopaths keep them on inhalational corticosteroids, right? And also on bronchodilators. And if it is associated along with the lung infection with different bacteria, they are kept on antibiotics. That is like symptomatic treatment. You are just slowing the process of lung destruction, but not treating, or you are not curing the total pathology, right? Then comes the airflow limitation. What is airflow limitation? The definition itself states that COPD is the airflow limitation, right? And it is progressive. The cardinal pathophysiology feature of COPD is caused by airway narrowing or obstruction, loss of elastic recoil, or both. Airway narrowing and destruction is caused by inflammation mediated. See, once the inflammation sets in, we have already discussed that neutrophils and macrophages will start playing its role. Once it is playing its role, what will happen is mucus will be secreting in a very high amount, right? That is the reason it will be narrowing the whole thing, the whole tunnel system. Let me keep it that way, because most of the people are unable to understand. The whole tunnel system will be blocked by the mucus secretions. Once the mucus secretion sets in, what will happen? Air is entering in, but it is unable to come out. So there is, what is happening? There is hyperinflation. Okay, lungs are hyperinflating. Okay, because air is continuously entering inside, but it is not completely going out. So lungs are hyperinflating. What will happen? Alveolar septa is destroyed. Because of all these conditions, the septa which are there in the alveoli are simply destroyed. Okay, and there is reduction in the parenchymal attachment to the airway. For example, so this is the terminal bronchiole. Okay, and alveoli are present over here like a balloon. Okay, once the air is entered, okay, and all the inflammatory conditions have been occurred, what is happening is the septa inside the alveoli are slowly disintegrating. Okay, they are disintegrating and they are forming a hollow structure, a big hollow structure. This is known as bulle. Okay, that is known as bulle if it is more than 1 centimeter. Okay, so bulle may be entirely empty or with strands of lung tissue transversing them in areas of locally severe emphysema. They occur in entire hemithorax and lead to the loss of elasticity and lung hyperinflation. So what is being lost? The elasticity is lost because now alveoli is unable to come to its original state and there is lack of perfusion as well. Now what is happening is the lung hyperinflation is happening. Okay. Since there is increased airway resistance, increase the work of breathing. Air is entering in, but it is unable to come out. What is the meaning of that? It means it is forming a resistance. So there is some resistance for the air to enter, to get out of the lungs. So this resistance causes work of breathing. So what will happen? You will start to breathe more. Since the patient is unable to expire, now what will he do? He will start to expire through his mouth. That is the reason the patient will present with a pursed expiration. See, it is very easy. When you expire through your mouth, it is easy rather than expiring through your nose, which is a little bit complicated, right? Expiring through mouth is easy. You can just do it yourself. Expiring through mouth is easy than expiring through nose. But that is a diseased state, not a healthy state, right? So lung hyperinflation decreases the airway resistance and increases the work of breathing. Increased work of breathing leads to alveolar hypoventilation with hypoxia and hypercapnia. What is happening? Since there is no perfusion, this is the alveoli, this is the parenchyma attached to the blood vessel. Since this is destruction has happened over here. Now the perfusion has to happen. There should be exchange of oxygen and carbon dioxide. Now this is destructed. There is no perfusion happening over here. Oxygen is not being transferred. What is happening? There is hypoxia, there is reduced oxygen, increased carbon dioxide. What will cause increased carbon? Like, what will happen if hypoxia sets in, and what will happen if hypercapnia sets in? What will happen if hypoxia sets in? Can anyone explain? Tell me what will happen when you see the blood report of a COPD patient. That is CBC. You know the CBC, right? Complete blood count. What is the first thing you will notice? Increase in RBCs. Why RBCs will increase? Because hypoxia is there. Brain will say, "Arey bhaiya, something is happening. Oxygen is unable to get inside the body." So what we will do? We will just increase the production of RBCs. Okay. Once we will increase the production of RBCs, even though small amount of oxygen, even though it comes in, we will just grab it and we will maintain the required oxygenation of the body. But that is not the case here. What is happening over here? The destruction is happening at the lung itself. Even though the body is trying to produce more RBCs, it is of no use. Right? That is the reason, even though RBCs are more, no use for the patient to feel free of breathlessness. He will be breathless, he will be short of breath, and he will be having cyanosis. Right? And in hypercapnia, what will happen is there is delirium. There is increase in carbon dioxide, decrease in oxygen. Brain will take only two things. What are they? Oxygen and glucose. The two foods which are liked by brain is oxygen and glucose. But here the oxygen is reduced. What will happen? There will be delirium. And there will be flapping tremors, and also there will be bounding pulse. I have already told you, hypercapnia will cause vasodilation. Since vasodilation happens, there is bounding pulse. But chronic type 2 respiratory failure will happen, that we have already discussed. But listen to this. Acidemia will not set in at a very initial stage. Why? Because the kidneys are retaining the bicarbonates. Since the kidneys are retaining the bicarbonates, what will happen is acidemia is not setting in. Right? Acidemia is not setting in because kidney is taking care of it. But as the disease advances, the kidney will stop doing this. And what will happen is acidemia will slowly increase. Since the acidemia is slowly increasing, what will happen is there will be respiratory distress. With respiratory distress, there will be drowsiness, because the brain is also not taking enough oxygen, and finally he will go into coma. Right? That is the pathophysiology. There are two types of people in COPD. One are known as pink puffers, and another one is blue bloaters. In pink puffers, people are thin and breathless with normal concentration of oxygen, and in blue bloaters there is hypercapnia, edema, and secondary polycythemia. Right? What are the investigations which we should carry out? What are the investigations which we should carry out? Because most of the people, what they will do is, starting from CBC up to they will write up to PET, positron emission tomography, because they will suspect that something is going on, some pulmonary nodule might have been there. Because see, it is all a big business. If you are unable to diagnose the case at the clinical stage itself with the help of your clinical knowledge, you will be writing unnecessary lab test to the patient. I know that most of the diagnostic center will be giving some amount to you, but that doesn't mean that you should move from your ethical corner and be in a place to write each and every test. Not necessary. Be in the position of the patient and understand what is the test which is necessary to, so that whatever you are thinking. Nowadays, what is happening is, let the test report come, that will show the diagnosis. Why should I take this risk? I'll just sit simply in my clinic. Let the patient come, let the diagnostic center take the headache. I'll write the test. He will give me the diagnosis. Then I'll start the treatment. That is the trend which is running now. That should not be there. We should form a differential diagnosis before we are writing a test. Once the test is written, then we should know that, okay, this is the problem. I have narrowed the differential diagnosis. And now what I have to do is, I'll start my treatment. Right? Treatment and the investigations, especially the investigation, should include the blood count. Because we know the pathophysiology of COPD. Right? We know that RBCs will increase. Right? And there will be anemia as well. We know that alpha antitrypsin is the culprit over here. What we will do? We will do assay of it. Okay. Chest X-ray. See, in chest X-ray, you won't be finding COPD. Chest X-ray is not for COPD. Let me clear it again. Most of the people, they will see the chest X-ray. This is COPD. No, it is not for COPD. It is then alternative diagnosis, but not for COPD. What is the alternative diagnosis then? Alternative diagnosis will include, can anyone tell me what will be the alternative diagnosis? Whether there is any enlargement of heart, right? Whether there is consolidation, bronchial asthma. So that is for alternative diagnosis. Okay. Then spirometry. In spirometry, let us state that the spirometry is like the gold standard nowadays. Once it was body plethysmography. Right? Body plethysmography was the gold standard. Now it has changed and it is the spirometry now, which is more convenient. And also it is cost effective rather than going directly to the HRCT. HRCT is like another gold standard. But what is happening is, most of the patients are not, even though you write investigations, under investigations, go get done a HRCT done, but they won't be going. What you have to do is, you can simply ask them to go get a spirometry done, in which you will understand the lung volumes, how the lung volumes are there, like how efficiently the lung is functioning, right? Pulse oximeter. When you see the pulse oximeter, as soon as after COVID, pulse oximeter is like in everyone's desk, right? So as soon as you start to feel cough, definitely once or twice you will be seeing your pulse oximeters, saturation, oxygen saturation. In COPD patients, the pulse oximeter will be showing less than 90%, right? Because he is hypoxic, right? And also in HRCT. HRCT is for detection of the COPD. And characterization and quantification of emphysema. And also it guides the lung volume reduction surgery. That means HRCT is important for lung resection also. If a part of the lung is totally gone, no one can rescue it. Simply what they will do, they will be guided. The surgery will be guided by the HRCT, and there will be a reduction surgery. Lung reduction surgery will be there. So that is the use of HRCT, right? Then assessment and questionnaire. This is very important. As soon as the patient comes in, you should have a COPD assessment. No need to have your own take the whole case. But to understand the prognosis, you should have a certain criteria. That is an assessment protocol. How will you understand that? How will you know that the patient is improving or the patient is deteriorating? Through assessment protocols. There are 2 assessment protocols which I want you to know, because this is the gold standard in assessment, not in investigation. One is COPD assessment test. This is an online test which you can simply give it to the patient, or you can ask the patient There are a set of 10 to 12 questions in it, and it will be marked from 0 to 10. Right? And he just have to mark the number of points which he has to. You can see it now as well. In your phone, you can see the CAT, that is COPD assessment test. In COPD assessment test, there will be a control questionnaire. There will be a questionnaire of 10 to 12 questions, right? In that 10 to 12 question, what he will say is, he will be giving a set of numbers to each question, a rating system. Okay, and in which you just have to rate it. Once the rating is done, all the points will be calculated. If it is more than 10, and what will happen if it is less than 10? That is a prognostic criteria. Okay, that is a prognostic criteria. And also there is this assessment for COPD known as gold assessment for COPD. What is gold assessment for COPD? It is Global Initiative for Chronic Obstructive Lung Disease. Global Initiative for Chronic Obstructive Lung Disease is the assessment. And also this initiative releases all the statistics related to COPD every year in the form of a journal. And you can assess this online as well. Right? Then clinically relevant assessment. What is clinically relevant assessment? That which you do in the clinic. Assessing the symptoms, limitation in activity, frequent exacerbation. Whether the patient is showing any limitation in activity from prior consultation, or are there any frequent exacerbations which are happening after the treatment has started, right? And also assessing his symptoms. How is his cough? Whether expectoration is increased or reduced. How is the breathlessness? Has the edema increased or has the edema reduced? So all the things has to be done in the clinic by you. That is clinically relevant assessment. So there are 3 assessments. One is COPD assessment test, gold assessment for COPD, which stands for Global Initiative for Chronic Obstructive Lung Disease, and clinically relevant assessments. There is a scale for understanding the dyspnea as well. That is known as MMRC scale. In MMRC dyspnea scale, it will be graded from 0 to 4. Okay. So 0 to 4 stands for, in grade 0, there is no dyspnea. Okay. But only on exertion, that too after doing strenuous work. The second grade is, that is grade 0. The grade 1 is dyspnea when you're walking uphill. Okay, when you're walking uphill. Tell me a drug which is also known as mountaineer's dyspnea. Coca. Right? So you can say that can we say that mountaineers, the grade 1 sets the coca, because the dyspnea happens when the person is going uphill, because it is causing acute mountain sickness to him. Right? Acute mountain sickness causes dyspnea. Dyspnea causes, again, what will happen? If dyspnea is there, hypoxia sets in. Right? For that, in our materia medica, we have coca. Coca is also known as erythroxylum coca. And in grade 2, we have dyspnea when walking on level ground. Dyspnea on walking on level ground. And also, he will stop for 50, like after walking for 15 minutes, he will stop and then he will start again. Right? Grade 3. Now, grade 3 is, he will walk for 100 meters, he will sit for 15 minutes. He will walk for 100 meters, he will sit for 15 minutes. And in grade 4, he will be panicked even to go out of the house. And that kind of dyspnea he will be suffering with. Grade 0, grade 1, grade 2, grade 3, and grade 4. What is the aim of the physician here? Improving breathlessness, reducing the frequency of exacerbation, reducing the severity of exacerbation, and improving the health status. This has already been taught by our master Hahnemann. Now they are telling us, but we also already know them like 200 years, from 200 years. Allopathic approach, as soon as the patient comes in, he won't come to the homeopath directly because COPD is such a disease which causes panic in the patient. He will hurry to the allopaths first. He will take bronchodilators because he is having dyspnea. He will take, since bronchodilators are given and they have already diagnosed them with COPD. That means inflammatory conditions are happening. What they will write? They will write corticosteroids. Since corticosteroids are also there and bronchodilators are also given, I urge you to go through the treatment aspect of the COPD patient, right? Because you will get hints from that. See, whenever you are getting a patient from modern system of medicine, what you have to do is, even though he is telling a wide array of symptoms, like I'm having hoarseness, I'm having dyspnea, I'm having skin eruptions, I'm having oral thrush, I'm having headache, I'm having irritation, muscle aches. These are all not the real picture of COPD. This is a combined picture of COPD. This is a combined picture of a disease. That which is formed by a natural disease and that which is formed from a allopathic drug disease. Now let me showcase how it happens. When the person is taking bronchodilators, side effects will include nervousness, headache, throat and nasal irritation, muscle aches. And also combined inhaled glucocorticoids and bronchodilators will cause hoarseness. నా పేరు ముఖేష్ యాడ్ తెలుసు కదా అందరికి. నా పేరు ముఖేష్ అంటారు కదా. What is that? There is hoarseness. You can clearly observe hoarseness in that. That is not because of the disease. Hoarseness was not because of the disease, but it was a combined, it is a side effect, right? It is a side effect of glucocorticoids, right? And oral glucocorticoids like prednisolone, what is the side effect of that? That is osteoporosis. Okay, what you will say? They will say that bones and pain outunnayi. I am having all the pains in the bones. I am unable, I have muscle aches, right? Don't think that it is a viral illness. Patient is having respiratory complaints, patient is complaining of joint pains, patient is complaining of muscle aches. This is viral illness. Don't do that. Understand the disease, understand what treatment he has underwent, right? That is more important. Once you distinguish the actual natural disease from the medicinal disease, from an allopathic perspective, that then you have to start the treatment, right? That is why Hahnemann told ki whenever a person is coming from other system of medicine, wait or antidote him with Nux vomica, right? It is not just Nux vomica with which you should antidote, because tell me this, if a person has been overdosed with steroids, what you should give? Nux vomica won't work in that. Calibike can be given. You can try you can try tautopathic drugs. You can try tautopathic drugs. Patient, for example, a patient suffering from viral illness will be bombarded with Dolo 650 3 times a day for at least 10 days. For at least 10 days. I have attended a seminar, pharmacy seminar, which was hosted by a Canadian pharmacist who told in the seminar that paracetamol and Dolo, they will stay in your liver for 90 days. One tablet. One tablet will be staying in your liver for 90 days. So that, let me do the math. 3 tablets, 10 days. 30 tablets, 10 days, right? The 30 tablets you are consuming, how many, like how many days those will be staying inside your body if one tablet stays for 90 days? Nine threes are 27, right? 2,700 days. One year has 365 days. So how many years it will be staying inside your body? That is the effect, right? That is the effect which you have to understand. What is the cause? What is the treatment taken? How you are distinguishing it? Whether the person is coming to you with a proper natural disease or has been adulterated. He has been adulterated with a medicinal disease. Like whatever we are eating nowadays, it is completely adulterated. But we have to eat it, right? There is no option. Sarigga proper. If we eat a proper diet without any adulteration, we will die. That is for sure. Our body can't take it. Literally, our body won't take it. It will feel that it is a toxin to our body. So in treating these kind of diseases, after going through allopathic approach, you should understand what kind of treatment is being given, what are the side effects of the treatment. If the patient is coming and sitting in front of me, whether he is suffering from an allopathic disease or a natural disease, that will make you clear. And the drug, the choosing of the drug becomes easy, right? They will be giving vaccinations, influenza vaccination, pneumococcal vaccination, mucolytic agents, benzodiazepines to reduce anxiety, morphine injections to reduce breathlessness in advanced stages as palliation. So these are all kind of palliations. I don't understand, like they are giving benzodiazepines. Benzodiazepines are, once you start it, it will be increasing. It is like a habit forming drug. You cannot taper it. Even if you taper it, it won't do the necessary thing which actually it needs to do. I have patients who are been using benzodiazepines coming to me telling me that, sir, for anxiety, I'm okay. I'm taking this medicine. I'm taking benzodiazepine, but my sleep is also set. Everything is set. I'm feeling drowsy. I was started with 0.25 mg. Now I'm at some higher dose. And always I'm asking my doctor, when will you taper it? He will say, oh, no, it's okay. It is not causing any harm to you. Rather, it is giving positive benefits to you. They will always keep you in shadow. No one needs to know this. No one will ever need to know this, that benzodiazepines are the major culprit of actual anxiety disease. Rather than, what you should do is, there are many other options other than benzodiazepines. Even after many years of treatment for anxiety, people will end their lives rather than tapering the drug. It is a habit forming drug, totally habit forming drug. That comes to the end of the pathophysiology and how COPD works. Now, this is the case which I have treated. It is a case of M5 Hima. She's I don't want to reveal her name. So she's Mrs. R, who is aged 41 years, female. She's an outsourcing employee. She's a resident of Old City. Her chief complaints were breathlessness and cough with expectoration. History of presenting complaints. Patient was apparently healthy 3 years back. She gradually developed breathlessness, which aggravated on exertion. Ascending stairs. Later, even at rest. What is later means after 3 to 4 months. started even at rest. And while lying down flat in supine position, she has to sleep with elevated pillows, like at a 45-degree angle. If she doesn't sleep in that angle, she will feel suffocated. Right? Breathlessness was associated with cough, with profuse expectoration. Cough was continuous with whitish, yellowish, non-offensive expectoration. Right? When asked of any recent history of viral fever, like the COVID was like a taboo. Right? You will find patients, you will ask the patient, because long COVID it's like a fashion now. If any person comes, you will ask, sir, do you have like history of COVID, being COVID positive? Huh? COVID positive. Mere area, like in all the area, the only house which didn't get COVID is my house. I never got COVID. Because you know that the symptoms with which he's presenting is that belongs to a long COVID syndrome. But he will deny the fact. No, I didn't got COVID. I never had that. My neighbors got COVID. This neighbor got COVID. That neighbor got COVID. The other neighbor got COVID. My house was the only house which was not affected by COVID. After like second sitting or so, this patient revealed that she was affected by COVID. And for that, she didn't even go to hospital. She was being treated by a doctor in the same apartment. I don't know what he gave in that COVID pandemic situation, because at that time, no one drug was the actual drug for treating COVID, starting with hydrochloroquinones. Take hydrochloroquinone, it will reduce the fever, because we were the first line of defense. During COVID, us doctors worked in hospitals. We were given hydrochloroquinones to be taken for 1 week, I guess. And I don't think that was the actual medicine to be taken for a viral fever. Is malaria a viral fever? Is malaria a viral fever? It is not a viral fever. Is it any other fever other than is it a bacterial fever? No, it is not a bacterial fever. But we were bombarded with hydrochloroquinones. Stupid. That is illogical. Totally illogical treatment. And this woman was treated with hydrochloroquinones. This woman was treated with bronchodilators. This woman was treated with antibiotics, antacids, and also multivitamins. Every sort of like you can name the drug, she might have taken it. She presented with cough, fever, myalgia, vertigo, chest tightness, and weakness, and she recovered within a month. Obviously, if you take all these kind of drugs, either you will lose your life or you will lose your vital force, right? Because once you have taken all these drugs, the good bacteria will go, the bad bacteria will go, the pathogenic organisms will die, the antivirals will die, the viral pathogens will die, each and every organism will die, and you will be there. Just you will be there as a human, nothing else. No conscience, nothing. Right? What is happening is she took every tablet that was there on the table, like over the counter medication. I asked her, have you taken any other medication which was not prescribed by the doctor? Yes, she has taken it. If you want to take a tablet, that has to be prescribed by an allopathic physician. And if you are not taking those tablets which were prescribed by the allopathic physician, because risk-benefit ratio, they only know that. If you don't know the risk-benefit ratio, a person who has a pharmacy, allopathic pharmacy, doesn't know a risk-benefit ratio. Fever, पैरासिटामोल. क्या हुआ? Dust, the diarrhea. Okay, take this. He won't assess the risk benefit ratio. He has not underwent a 5.5 year degree of MBBS. So don't trust all these over the counter medication when you are not aware of risk benefit ratio. She took every treatment. And finally, she consulted. Nothing was happening. She was not feeling anything. Like she was unable to ascend stairs. She was unable to sleep. She was unable to work. She finally consulted a pulmonologist after 6 months. She suffered for 6 months. After 6 months, she consulted a pulmonologist who recommended her with HRCT, which revealed M5C matters changes in the superior basal segment of left lower lobe. So that is a diagnosis which happened. Until then, she was treated for COVID-19. Okay. After COVID-19, there was a phase in which she was symptom free, but there were few symptoms of shortness of breath. Like there were few exacerbations of shortness of breath, that is dyspnea, breathlessness, and also there was hypoxic kind of situations. So she consulted a pulmonologist and she was diagnosed with M5C matters changes in the lung. She was kept on bronchodilators, including inhalational ipratropium and albuterol. Corticosteroids were also recommended. Along with that, because she was so breathless, even on lying down, she was asked to carry a CPAP machine, continuous positive airway pressure, CPAP. But she denied it because even the thought of keeping something around the nose was causing her anxiety. Even though the CPAP machine will help her to reduce that breathlessness, she was not taking that. So I have kept a scanned copy of the diagnostic center and also the diagnosis which was there in the report. That is focal M5C matters changes seen in the superior basal segment of the left lower lobe. In life space investigations, when I asked her, like, what is your background and all, she hails from a low socioeconomic family. She was born and brought up in Hyderabad. She had 3 siblings. Everything was normal. She had a good relation with her parents. And also, she was married at a very young age of 19 years. She studied up to her degree. Like she studied till her degree. And after that, she didn't want to reveal each and every part of her personal life. She told me that her husband died at a very young age, and she later married a Muslim, and she was converted to Islam. Okay, so most of her personal history, it's like a blank, because you know how the society is. They keep judging. Even few people keep everything secret. But you can clearly see the anxiety in her face. Because anxiety is the thing which can be clearly observed in the face. Even if you, for example, if up till the time I come to this podium, you can see myself sweating. If you have observed or not, I will be sweating because I don't know how it will go. Right? But if you see me very keenly, you will observe that. The doctor has this power of keen observation. You can observe, okay, the person is having frontal sweat. The person is sitting very nearer to the chair, just at the edge of the chair. Just like if he says, okay, your consultation is over, he will run. Right? So, and also he will be frowning like this, or else he will be doing or contracting his forehead like this. So these are all the facial expressions which one has to understand. I'm reading a book actually on facial expressions. There was a researcher, Stanford researcher, who did research only on facial expressions for almost 10 years. If I may, I will share after the lecture, the book. In that, he understood that even the movement of a single muscle will be related to some emotion in the human. Like this person is hiding some emotion, but there will be certain leaks in the face. Okay, you see, this is more like wives are more, let me say like this, experts in understanding the husbands. If the husband says, no, I haven't drunk today, or I haven't met my friends today, she will just simply see at his face, no, you are lying. Those are known as leaks. Your face will leak all the details if you are a keen observer. I asked my patient, what is happening? Like, you're too anxious. This is the second sitting, but you're too damn anxious. What is happening? Tell me. It's okay. Then she revealed that she was converted to Islam. The name which is there in the diagnostic report, it's Radha, right? But her actual name is not Radha. It is something else. I will not reveal it here. It is something else. Okay, it is a Muslim name. No one, because every person will have some secrets. Those which are not to be told to others because they will take advantage of it. Right? So there is an anxious look. But at the work front, she's very particular. She will do the work given to her. She will sit there. She will complete the work. And she has never skipped a day. And she has never went to the office late. That is her track record. And she has been given certain award for that as well. Then in physical examination, there were no signs of cyanosis, clubbing, lymphadenopathy, icterus. She was positive for edema of the lower limbs and positive for pallor as well. Right? We have already understood positive why she. Now, just understand this case in the pathophysiology perspective. It will be very easy. Now, when I say she is positive for edema and she is positive for pallor, you will understand why she has pallor and why she has edema. Because if you know the pathophysiology, understanding the symptom presentation becomes easy. General respiratory system assessment, she is negative for sternocleidomastoid muscle action. Why sternocleidomastoid SCM? Because in short form, we call it as SCM muscle. Why it is important to understand the action of SCM muscle in COPD patient? Exactly. Accessory muscles will be working. Because lung functions have reduced. Accessory muscle functions will work. There is also she is also positive for audible wheeze. Even I could hear her wheeze. I was at a distance like up to 3 to 4 feet. I could hear the wheeze. Told by her husband and no hoarseness. Patient is obese with a BMI of 35. She was around 5 feet or so. And she had she was around, I guess, 90 kilos back then. I think so. Patient becomes breathless on lying on examination table. Now you can also understand that in differential diagnosis, you can also feel that patient is obese, patient is having a high BMI. She might have sleep apnea as well. Right? Because whenever she's lying flat, she's having breathlessness. That could be because of sleep apnea. Now you are trying to form a differential diagnosis out of it. Once you form a differential diagnosis, understanding and writing the investigations becomes easy, right? There is, and always try to note down the JVP, jugular venous pulse, is not raised at 45-degree angle. No flapping tremors. Flapping tremor happens in hypercapnia. More like increased carbon dioxide or fine tremors. Whenever there is a difference between fine tremor and a flapping tremor. Fine tremor happens when the patient is on continuous inhalational bronchodilator, like salbutamol. And flapping tremor happens when he is having hypercapnia, right? So you should distinguish between fine tremors and flapping tremors. Okay. Pulse rate was 90 beats per minute, and respiratory rate, she was tachypneic with 22 breaths per minute. Inspection done by, not by me, but a female doctor. Always try to remember, it is ethically correct to inspect a female patient in the presence of a female doctor or a nurse. Cases have been at a rampant rise nowadays. Even the patient, even if the doctor is seeing a female patient, she might book a case on you. Try to have a female attendant by the side, not of the patient, but of you. You should know the female attendant who is there, and try to put a camera in your cabin, because that camera will save you one day. Inspection done by female doctor. There were no scars, no lumps, no lesions. Shape of chest was, she has a slight scoliosis. Movement of the chest that is asymmetrical, slightly diminished on the left side. Palpation, no swelling or tenderness. Trachea position is slightly deviated to the right. Chest expansion 3 centimeters with slight diminished expansion on the left side. Percussion, resonance note. Auscultation, reduced breath sounds with bilateral V's. And on dyspnea scale, it was grade 2. Investigation suggested, what I have suggested was complete blood count, arterial blood gas. To assess the pH, I want to know whether any acidosis has set in, or hypercapnia has set in, concentration of carbon dioxide and concentration of oxygen. Sputum examination, I wanted to know whether she has been, there is any additional bacterial infection which was going on, because emphysema, we have already discussed that there will be formation of bullae, and if the formation of bullae is there, colonization of bacteria will happen. So sputum examination becomes important. Chest X-ray, PA view and lateral view should be taken. Spirometry and HRCT. Since HRCT was taken 3 years back, right? And no one knows how the disease has progressed. You can ask for a HRCT. So coming to our management thing, I have to take the mental generals. She was anxious and she was conscientious. Physical generals, she doesn't have any aversion or desires particularly related to food, and her appetite was reduced. We have already discussed this, right? Thirst for small quantities of water. Urine was clear, bowels were regular and soft, perspiration, profuse on face on exertion. Sleep disturbed due to SOB. Dreams, she doesn't remember any dreams, but I don't think so, because most of the time we will remember our dreams. Most of the time patient will tell all the lies. Thermals, towards chilly, complaints aggravated in the cold weather. So repertorization I have done. Mostly I take Murphy or complete. These are the 2 repertories which I try to prescribe from. And she was the first 5 drugs were Silesia, arsenic album, digitalis, lycopodium and phosphorus. I have prescribed her Silesia 200 based on the given symptoms. And I have prescribed her 200 potency because I believe in law of octaves. Okay. You don't prescribe based on susceptibility nowadays, because susceptibility will change. If you say that susceptibility is the response of the body for the external stimuli, susceptibility will keep on change every second, because every second our body will be responding to the external stimuli, right? So try to stick to certain principles, fixed principles, so that you can experiment it later. 200 is not working, go to higher potency, right? Tell me what potency comes after 200. People will say 1M. There is no potency in between, right? There is 201 potency, there is 202 potency, You can do that as well. That is known as experimentation in homeopathy. Right? People won't do that. They will directly hit 1M, they will directly hit 10M, they will directly hit LM potencies. Since she was being treated with steroids and anticholinergics, so we should be cautious in abruptly stopping the treatment. Never stop the steroid treatment. Never do that. Inflammatory process was happening. Steroids were trying to control it. Once you stop the treatment abruptly, the patient will have a storm inside his or her body. That storm will take away the whole thing. Right? Directly deathbed. Never stop the steroid treatment abruptly. Never start a steroid treatment abruptly and never stop one abruptly. What you have to do is taper it. Slowly taper it. Okay, so that the body will be acclimatized. What were the drugs which were given to the patient? One was anticholinergic drugs, right? And bronchodilators, corticosteroids. I have a MD in homeopathic pharmacy for 3 years. My topic was on toxicology. My topic was totally on toxicology, how a medicine will work at the cellular level so that it is producing this set of symptoms. So whatever I was learning back then helped me a lot. I know that these people were giving, like I should have some respect. So doctors were giving anticholinergics, corticosteroids. What I have to do? I have to choose a similar drug which will have the same action, same level of action of that kind of drugs, anticholinergics and corticosteroids. Since corticosteroid effect is on inflammatory response and anticholinergic is mostly on the muscles of the neurotransmitters and the muscles of the, like the skeletal muscles and all. What I tried is, I have checked the phytochemistry of aspidosperma. Because back then, for COVID-19, aspidosperma was like, give aspidosperma blindly. Don't even understand what is happening inside the body. Just give aspidosperma blindly. No, that is not the way how you should treat the medicine, treat the patient. Understand how the medicine is working. If the medicine is working in a particular way, you should know that, okay, this medicine is having this alkaloid. This medicine is having these phytochemicals. What is the biological significance? What is the medicinal uses of it? Understand that. If you correlate these two things, there are wonderful drugs which have the same similar properties to that of the synthetic drugs. Where do you think that these drugs have been taken from? Synthetic drugs are similar to the drugs which they have, from which they have collected. For example, the source of, where do you think the hydrochloroquinone came from? Exactly. The active principle lies in the nature itself. We have to understand what is the active principle in the nature. We have to understand whether there is any toxicity which it is causing to the body. According to that, we have to prescribe it. I started tapering the steroids by giving her aspidosperma. After giving aspidosperma and a constitutional remedy of Silesia 200, she responded well. Okay, because COPD is not curable. COPD is not curable. It is treatable disease. Never say that, see, if a person is coming to you with all the hope, don't say just for the sake of the patient, you will be cured. Don't do that. Don't give false hope to the patient. Right? Be logical with the patient. If it is a treatable disease, say that it is a treatable disease. The life expectancy will be similar to a normal person, and also the quality of life will be normal. Because in all these diseases, what is being adversely affected? Quality of life is adversely affected. Just imagine not able to sleep on the flat ground. How troublesome it is. You are like totally sleepy, but unable to, there is a bed which you have bought for 1 lakh rupees, useless. Quality of life is missing. Once there is lack of sleep, that will be affecting the work which has to be done in the next day, right? Your immunity goes haywire, right? If your immunity goes haywire, what will happen? The quality of, not only the quality of life, but your productive years will be affected. If you're productive, for example, you will be productive from 18 years up to 55 years or 60 years. For doctors, till death, right? At least we are like a bit lucky. We don't have retirements. Nah. So in general, from 18 years to 40 years, if we say that 18 years to 50 years is the productive life of a normal person, if the productive life is being affected by a disease, a chronic disease, for let's say 10 years, just imagine how much he will be earning, how much he will be losing to the disease. India becomes, there is a report which states that just a hospitalization can make, in India, just a hospitalization of a person can make him bankrupt, can make him poor, can make him down to the road in no time. Do you know just the treatment of COPD will cost you lakhs? Understand that even just a ventilatory system, right? If the doctor is asking that, okay, let's start with ventilation. Khatam. The person who is the earning breadwinner of the family, what will happen to the total family, and what will happen to his economic status, and what will happen to his life, right? So you should be very careful in telling to the patient, in advising the patient whether the disease is curable or the disease is treatable. Never give false hopes. Okay. You have to develop this communication skill of giving this advice. This is not the proper way to convey the message. See, your disease is chronic. We will be treating your disease and you will have a normal lifespan. This is the way you convey to the patient, right? Rather than abruptly saying, your fate is like this, it won't be cured. So conveying is also an art in medicine. You know how cool the doctors come and say, sorry, we could not do anything, the patient is dead. Have you seen this? It requires so much courage. So conveying a message is also important. Communication skill is very important. So in the follow-ups, she came to me on 10th August 2023 with breathlessness on lying down, whatever complaint I have told you, for which I have prescribed her Silesia 200. On 23rd, her cough reduced by 70% and expectoration reduced, but breathlessness was still there. Okay, so I have given her SL, and because it requires some time for our medicines to work, and also breathlessness, we know what was the reason for the breathlessness. Okay, so emphysema, it won't go like the corticosteroids and all, it won't go like that. In homeopathy, it will take, because all the pathology which is there in the emphysema, it requires certain time to cool down. It is not like a miracle, so that once I give the medicine, every inflammatory process will be going out of the body. So the third consultation was on 15 September 2023. in which breathlessness, now the breathlessness was better by 15 to 20%. Okay. I kept her on Aspidose Perma Q and I was just tapering the steroid dose. Then she came on 20 October 2023, where the breathlessness was better by 40%. And still I was kept her on Aspidose Perma. And the recent consultation was on 12/11, that is on November 12th. The eruptions, now I don't know, like I have to check again, because people always remember one thing: patient will always lie to you on your face. That is a gold standard. If a patient is coming, don't take every word coming from his mouth that he will be telling truth to you. You are not a judge, High Court judge or a Supreme Court judge. There is no Bhagavad Gita in front of you. Take a vow and tell me all the truths. Right? Patient will be hiding things. For example, eruptions on the back. In the recent consultation, she had eruptions on the upper back. I have to check again. In next consultation, I will be doing that. I have to check whether she has taken any in-between treatment or not. Okay. So, but breathlessness has been relieved by 50% and she is able to work now, and she is able to ascend stairs, and she is able to sleep on flat ground. Okay. And management of the case, you have to not only giving medicine is the main criteria, but also diet and breathing exercise play a major role. Right. So diet, protein-rich diet and carbohydrate controlled diet should be there. Why protein-rich diet is important in these kind of patients? Because the muscles are being overworked. Right. So protein-rich diet is important. Potassium-rich foods is important because hypokalemia sets in and acidemia. If once hypokalemia sets in, acidosis sets in. Right. So potassium has to be there. Hydration should be maintained. Breathing exercises are very important. I'll tell you 4 breathing exercises, which if at all you come across a COPD patient, you have to advise them. One is pursed lip breathing. Pursed lip breathing means ask them to inhale for 2 seconds. Count for 1 and 2. Then ask the patient to exhale through the mouth very slowly. This is pursed lip breathing technique. Okay. The pursed lip breathing technique will help the muscles, okay, the respiratory muscles, the diaphragm to be normal, okay, to function properly. The major thing is whatever we are advising, that is for the rehabilitation purpose. Okay. It is not for curing the disease. Okay. Fracture, see, after a fracture, after a road traffic accident, okay, surgery is important, not rehabilitation first. You can't rehabilitate with a fractured leg, right? So treatment first, rehabilitation next. So whatever breathing exercise which I am trying to tell you is for rehabilitation purpose. Next is deep breathing. Sit in a comfortable chair with elbows wide apart. Okay. Have you ever seen that whenever you bring your elbows near, you won't be able to take a deep breath, right? But when you remove your elbows apart, okay, whenever you push your elbows apart, what happens is it gives room, right? So deep breathe, then again exhale, not with mouth, with nose, right? Then huff cough. Huff cough is a breathing technique, okay, where you just have to give a small cough, okay. This is good for bronchial asthma patients, okay, because COPD also covers bronchial asthma as well, right? It clears the airway, okay. Huff cough will clear the airway. And diaphragmatic breathing, that has to be done on a flat level ground, because most of the COPD patients might have breathlessness. So ask the patient whether they are comfortable in that position first, right? After sleeping on a flat level ground, ask the patient to keep one hand on the thorax and the other on the abdomen. Ask the patient to take breathe. If the abdomen is moving, that is well and good. Okay. The beauty standards nowadays have improvised in such a way that if anyone is doing abdominal breathing, that is taken as a like, what are you doing? Are you an ape? Abdominal breathing is the actual perfect breathing technique. You should have proper abdominal breathing. Diaphragm should go down. No, that doesn't happen nowadays. Beauty standards, Instagram standards have masked all these things. Then finally, homeopathic drugs for COPD, that is ammonium carb, antim-ars, antim-tart, arsenic alb, heparsulf, lacasis, lobelia inflata, pulsatilla, and silesia. These are the most common drugs which are used in homeopathic treatment. Rare drugs like coca, naphthalinum, and aspidosperma. These are the rare drugs which you can use. Okay. Coca, it is a mountaineer's drug. And also you might, let me tell you this research. This is a small, sir, if you may, I'll just take 5 minutes, sir. This is a research where it was conducted on expedition for mountain expedition, those who were going to Everest in the year 1998, I guess. For those mountain climbers, what happened was these people, researchers gave to 11 mountain climbers, they gave coca, mother tincture, and the other 13 were given placebo. To these 11 mountain climbers or the mountaineers, the acute mountain sickness didn't happen. They were free of acute mountain sickness. They were adapted easily to they were acclimatized to the elevation. But the other 13 people, they had hypoxia, they had delirium, they had the mountain sickness. So this was a research which happened in 1998 on the Everest Mountain Expedition Camp. And let me tell you, there was a DPAS. DPAS India has developed a homeopathic formulation known as DIP3 using alcoholic leaf extract of plant Erythroxylum coca as a mother tincture. And these people have been giving to the mountaineers in small doses so that they can acclimatize to the sudden inclination in the mountain. So to end this here, COPD is a chronic disease. It is a progressive disease. With homeopathy, you can treat it very effectively. But rather than suddenly stopping allopathic medication, you should, if possible, ask the allopathic physician. There is no problem in that because nowadays, allopathic physicians are more open to complementary medicines. Okay, ask permission, take permission from them if possible, and start your treatment. Take proper care. Understand what is the pathophysiology of the disease. Don't blindly take every symptom and give the medicine. Understand, distinguish between a medicinal disease and distinguish between a natural disease. Then give the medicine. You need to have rehabilitation and also you need to have diet. So that for this, and also all the symptoms in the COPD can be managed with homeopathy. With this, I end this discussion over here. Thank you for giving me such a stage on which I can provide lecture. Thank you, sir. Thank you all the panel members and thank you audience. Thank you. Good evening.
Thank you, sir, for your elaborate oration. Now I call upon Dr. Goutham sir to summarize the session.
Good evening, one and all. It is such a pleasure for me to stand alongside my junior, Dr. Ramana Rao. It's a pleasure and a proud moment as well for me, having sharing the stage alongside you at the prestigious HMAT that we were discussing all the time when we are doing our MD. He's my junior in UG as well as MD, Dr. Ramana Rao. It also reminds me the time we shared, the happy moments, the tea cups we shared, the lunch boxes, of course, discussing good knowledge alongside, and very good partners in sports as well. Thank you, Dr. Ramana Rao, for such an elaborate presentation on COPD, and also the specific detailing on the pathophysiology and investigations, which most of the homeopaths, I would say, because I've been interacting with many, which many of the homeopaths, they don't try to discuss the pathophysiology, the investigations as well. We more concentrate on symptoms, right? It is important homeopathically talking on symptoms, but how important it is to discuss on pathophysiology and investigations and correlating them with the homeopathic principles simultaneously. This is what the sessions at HMAT are. We are waiting for people like you to deliver such an elaborate sessions. Thank you very much for such an elaborate session. And also the points you stressed on, like observations while the patient is telling his complaints, and also the observations while we are taking the case, like how the patient is responding to your questions, how important it is to express to learn the expressions, to analyze the expressions of the patient, and again correlating them with the homeopathic materia medica, and thereby using the repertory and prescribing. So we love your presentation, and we have few questions from audience online. There is a question from a gentleman, Dr. Arun. Why didn't you start the treatment with 30 potency? Why didn't you start the treatment with 30 potency?
Is it audible?
Yes.
Actually, she took a homeopathic treatment at her home as well,
Okay.
where 30 potency was already given without any proper, let's say, it was not useful for her to relieve the symptoms. So I didn't start with that. I gave a higher potency.
Right. So another question from the same gentleman. So how to assess, as you're prescribed single dose of Silesia and followed by aspidosperma, what has helped the patient?
What has?
The Silesia or the aspidosperma? That is the question.
So see, the symptoms of Silesia and symptoms of aspidosperma are two different things. I already stressed that I want to taper the steroid action. For that to happen, aspidosperma has played a major role. Once the steroid effect is masked out, Silesia will have a ground to act. That is the reason cough has reduced. And again, slowly the breathlessness have been reducing. And she's still under my treatment. There is still a pending HRCT, right? Because emphysema, COPD, it's not a seasonal disease like flu. It is a chronic progressive disease.
Yes.
I have to travel with her for next 2 years or maybe 3 years. It will give a more enhanced, more in-depth understanding of the treatment aspect as well. That is the reason the topic was homeopathic approach and management, not homeopathic cure.
Yes. Thank you. Thank you for such an explanation. Yeah. Now, do we have any questions from the offline audience as well? Anyone from the audience, you can ask a question. I think this sums up the oration. Yeah, please. Thank you, Dr. Ramana Rao, for your presence and your elaborate explanation. Thank you.
Now I request Team HMAT President Dr. K. Gopal Krishna sir, Vice President Dr. Manik Prabhu sir, General Secretary Dr. Durgaprasad Rao sir, and Treasurer Dr. Venugopal Gouri sir to please present a memento to our speaker. I request our Joint Secretary Dr. Goutham sir to please accompany. Thank you, sir. Now I request Dr. Venugopal Gouri sir to please give the vote of thanks.
Thank you, Dr. Shruti. Very good evening to everyone again. It was an interesting session from the learned speaker this evening, Dr. Ramana Rao, and we look forward to more interesting things to come up in the days to come from our stable here at HMAT. And it was an interesting session because it is a disease that has been occupying the clinics of the world over, especially after the COVID has taken over. It has added a new pathology to the disease, and stressing and pathophysiology of the disease is vital, even when a homeopathic prescription is concerned, and rightfully done by our speaker this evening. And in fact, it is when, as he has rightly pointed out to the fact that the respiration which is impeded, which is not cleared out, basically the expiration of air is not totally done. That is the reason for the why we call it as chronic obstructive pulmonary disease. And as our speaker also has said about Murphy repertory and complete repertory, I'm also a fan of Murphy repertory. And the same repertory says that you check into the rubrics and sub-rubrics of the breathing chapter. It will say, like, when expiration is difficult, there are few beautiful remedies like sambucus, which it may sound very simple or a small remedy, but it goes a long way in helping clearing the, improving the respiration. And there are other smaller remedies like chloralum. And of course, again, medorinum. And again, that's of course a deep acting remedy. Probably it suits well when things like interstitial lung disease also have had a miasmatic influence and caused such a pathology. And Lacus is a beautiful remedy that helps in improving circulation, relieving congestion. Opium is another remedy, which is a great thing also for things like sleep apnea, which falls similar as far as the pathology is concerned. So I think sticking to constitutional remedies, what our repertories point out, is a great idea. And apart from that, if we can also churn in some smaller remedies, that will go a long way in seeing that the patients do not require steroids for a long time to come. And I think we should take clue from our repertories where, with the pathophysiology of the disease is beautifully, if we can go through every sub-rubric, it does point out to our homeopathic therapeutics. I think we should take cues from that and prescribe more, as our speaker has said this evening. And we thank the family of Dr. B.K. Kumar for instituting this lecture. And the good officers of our association have been doing this memorial oration for over 25 years now, thanks to their good sponsorship and help. And we thank our team for coming up with the necessary information on time-to-time basis and reaching out to the people and making them understand that there is a seminar going on here. And we thank our secretary for the able guidance and our president for the leadership that has been carried out. And in the days to come, we look forward to better things to come in the future. We thank Dr. Goutham for the discussion, and thank you all for coming over this evening and having a good knowledge fair. And I'm sure in the days to come, as we promise, there will be better things as we have seen today. We'll stand up for the national anthem.